around 1940, 1950. We didn't even know what caused it. And we really focused in on men at that point in time. And with good reason, I think. So, men do get more heart attacks than women, and they get it at a younger age. And in that day and age, they died from them. And so these were men who had families, who were out working, and so we focused on them to figure out what was wrong in causing heart disease. The problem is that as time went on, we continued to focus on men. We continued to enroll men in our studies. We did not put women in our studies. We under-enrolled women in our studies. And so what we have today is a body of knowledge that's really based on men. And we've decided, well, we're going to just use that. It must work for women if it works for men. And the question is, does that actually work? All this data we get is very important to how we practice medicine, right? So that's how we decide how we're going to take care of you, are these research studies and the data we get. In fact, our guidelines are all based on data. If you look at the prevention guidelines that we have for women, and we can all be like, oh great, we have prevention guidelines for women. They used 156 randomized controlled trials to put these guidelines together. A total of the women in this group of these studies, 30%. 70% men in these studies. Of these studies, only a third actually even looked at sex differences, differences between women and men. 20 of these studies were men-only studies. So this is the data that we're using to care for our women patients. And so where has this gotten us? Well, it hasn't gotten us very far. So we know that more women than men have died of cardiovascular disease every year since 1984. We know that 1 out of every 4 women will die of heart disease, and 1 out of every 2 women will die of cardiovascular disease. We know that heart disease kills 6 times as many women as breast cancer, and it kills twice as many women as all forms of cancer combined. If you are a young woman under the age of 50 coming in with a heart attack, you are twice as likely as the same age man coming in with a heart attack to die. So this has not gotten us well. This is not working to take data about men and apply it to our women patients. And so we need to correct this fundamental flaw in hoping to take care of our patients. So the other thing that's come out of this history, I would say, is that we have this whole paradigm around heart disease is a man's disease. It's very entrenched in the medical field and also then, of course, in the lay public. It's gone on for years. I graduated with that vision, right? I had this idea that men get heart disease. We still somehow train physicians to kind of think that. And ultimately, until we change that paradigm, we're going to have a hard time changing the way medicine is practiced. So that's another problem that we have. If you look at cardiovascular disease or heart disease, there are an incredible number of sex differences that have been found over the last 30 years. And if we could take heart attack for an example. What about heart attack? What's different between women and men? Well, so women, first of all, have different symptoms when they come in. So chest pain is still the most important symptom, but women's chest pain may be different. It may not be their primary symptom. It often goes up into their jaw or into their back. So it's not always this classic hurts in my chest, down my left arm sort of pain. Women also tend to have a lot more symptoms when they come in than men do. So they will also complain of shortness of breath, palpitations, fatigue, nausea, those sorts of things. And so even recognizing that a woman's having a heart attack, you need to understand there's a difference between the women and men. Women in general don't think of themselves as people who are going to have heart attacks. So they actually underestimate their personal risk of having a heart attack. And in doing so, then don't recognize these symptoms, right? I don't need to know. That couldn't possibly be me. And so they're not even recognizing that they might be having a heart attack when they do. So consequently, they're later to seek care and get care while they're having a heart attack. If they actually do call for help, it turns out the EMS people that come, there's a 50% greater delay in women than in men, which is very interesting. It's like, why would that be? Well, it turns out it's not in transit time, so they drive just as quickly. But something on the scene, they're taking a lot longer. Some of this could be that maybe they have the same thing. Well, a woman, she's probably not having a heart attack. Maybe the woman is kind of underrepresenting what's going on with her because she thinks I couldn't possibly be having a heart attack. The other thing is I asked one of my EMS friends, I said, why would this be that there would be such a delay? And he said, well, whenever I go to take care of a woman, she always seems to have all these other things she needs to get done. And so there may be a social problem as well, right? He's like, well, they need to make sure that dinner, the husband knows where dinner is, that the last load of laundry's been folded, that they have their purse and all their things in it, and they're wearing the right clothes. And so this is an issue as well, right? And so we need women to say, I'm having a problem, take me now. Everyone else is going to have to deal and fight for themselves. So once a woman actually gets to a hospital, the chances are less likely she'll go to a hospital where we can take care of her. So you need to go to a cath lab if you're having a heart attack so we can open your artery. So she's less likely to present to that type of hospital. If she gets there and actually has her artery open, she's more likely to bleed in the cath lab, 2 to 3 times more likely that if we go through the groin with a man or a woman compared to a man, which is one reason that we prefer to go through the wrist, particularly for our women patients. That's something that I started doing 5-6 years ago now and train people all over the US to do that. That's one way I've kind of pushed sex differences on doctors without them knowing that they're helping women, is to teach them to do this. Women are also less likely to have blockages when they come in with chest pain or with a heart attack. Another area I'm very interested in is why are they having all this chest pain, but we can't see kind of a classic blockage and what's going on there. When the woman finally gets out of the hospital, she's less likely to go home on the drugs that she should go home on. She's also more likely to have depression following her event that ultimately affects her outcome. And so all of these things happen just in the context of a heart attack. So the range of the sex differences that we see is startling. So in the clinical context, we need to be thinking about that all the time. We need to know this, and most physicians actually don't know these things that I've just told you about. And then we need to be practicing differently in hopes of improving the outcomes. So that's what we do at Women's Heart Health every day, is that we're trying to take at least what we know from the literature and apply that to our patients so that we are practicing in a manner that's consistent with the patient that we're taking care of. The other thing that we really want to do, of course, is advance the science, and we want to improve the clinical and basic science research. The clinical research at this point is basically retrospective research, which means that a study was done on something, and then we went back and we said, well, how did the women do and how did the men do? And that's good. Like, we need that. That's the way I can know all this information, is from people kind of going back and doing this retrospective analysis. But ultimately, that's kind of a lower tier kind of research, and it really only is hypothesis generating, which means that it only gives us an idea that there could be some sex difference there. And ultimately, we need to be doing higher level science. It needs to be prospective, and we need to figure out not only why is there this problem here, but how do we fix it. One of the interesting things about doing this research in sex differences is that often people think, oh, if you do sex difference research, you're really just paying attention to women. But in fact, doing sex differences research is about understanding men as well. Because both of the sexes end up kind of diluting each other in the data, right? So if I find out, oh, this procedure is very helpful in patients. This is actually a true example. It's like, oh, if you take people very quickly to the cath lab, they do better if they're having a heart attack. It turned out that, yes, that was very true in men, but it wasn't true in women. And that at least with a small kind of heart attack, it may be better to delay longer in women. So in that situation, at least the men's data came out. There were enough men in there that you could see the positive effect, but you couldn't see the negative effect in women. It could possibly be that the negative effect was so strong in women that it could dilute the data on men, and we could say, oh, this isn't beneficial in anyone, right? So drawing that information out is very important to understanding the science. So I think the science gets probably even more interesting if you look at a basic science level, right? So when we start looking at cells, and animals, and recognizing that cells and animals all have sex also, and that most of our drugs and devices basically go through this pipeline where they start studying at the cellular level, or maybe they're doing it in rats, and then ultimately this comes up to humans, and then it goes out into the population, and you guys all start taking this drug. So what happens if they studied male cells, and then they studied male rats, and then they had mostly men in their studies, and then suddenly you get this drug, right? That doesn't make much sense. And how does that drug work for you, right? So the Ambien thing was a similar example to that, I would say, where it was like, oh, there's actually this difference that we forgot to mention along the way. And it's interesting in the basic sciences because they have the same sort of mindset as the clinical scientists, which is sex doesn't matter. And that they don't think about it at all whatsoever. And it's just startling. If you ask them about it, which I love to do when I meet a basic scientist, I love to say, well, have you thought about sex differences in your research? And they always like stop, and then they're like, oh, you know, that's interesting. And once you get them thinking about it, they're actually very excited about the idea. But most of them just don't think about it at all. And it turns out they study mostly, and particularly the animals, mostly males, because male rats or whatever they're studying, mice, don't have hormonal variations. Right, so they're not annoying. So with no regard to the fact that all women do have this, and that it might be nice to know about it, but that's why they like to stick with the male animals. It also turns out that they're actually cheaper to get male animals, so that makes sense, right? If you're going to do research, you would get the cheaper ones and the ones where it's easier to do the work. Most of the time we find a sex difference in basic science, it's by accident. And I had a great example of a woman I met just last week, a basic scientist. She was looking at pulmonary hypertension, and so this is where you have high blood pressure in your lungs. And this is a predominantly female problem. And she was studying this, and she found an inhibitor that when she gave to her rats, this pulmonary hypertension got better. And she's like, oh my gosh, right? And that's exactly what you want, because this could eventually turn into a drug. And so she called up the place where she got her rats, and she said, I need some more rats. You know, I need to do some more research. And they said, well, we can send you rats, but all we have are female rats. And she was like, well, that's fine, you know, but she had been working predominantly on male rats. So she suddenly gets all the female rats, puts her inhibitor in, and it doesn't work. And she was like, oh my gosh, right? And that was by accident. She wouldn't have known otherwise. So this happens all the time, or it doesn't happen all the time, meaning that when it happens, it's an accident, and you can imagine that how many times we miss stuff because we fail to take that extra step. So I think in addressing the problem, this fundamental flaw of not taking into account sex differences, we have a lot of work to do. So we really need to focus on the education of people, particularly physicians. We need to focus on them, but also we need to get the public understanding this as well, because they often become the primary force by which physicians have to do something, and they're kind of like, oh, I guess I have to get out of this paradigm that I'm in, and that's very comfortable. We also need to continue to work on the clinical care, and as the data comes in, we need to understand it, we need to incorporate it into the way we're taking care of our patients, and we need to do that regularly in hopes that we will improve their outcomes. And then we need to continue with the research as well, and we need clinical research, and we need basic science research that's looking at sex differences, so that the data that we have will, again, affect our care and get the word out to everyone. So that's really the vision that we have at Stanford for tackling this problem. And you know, it's very important, I think, that we do this and that we have to come at it on all fronts, certainly. We can't just do it in one area. So it's a big vision. It's about overcoming an entire paradigm. So it will be a challenge, but I think it's one that we're very highly poised to do at this point in time. And I think Stanford's a fantastic place to do it, and probably one of the few places, if not the only place in the country that is ready to do that. We have a fantastic women's heart health program We have a great clinical program, certainly. You have met some of my colleagues, and you will meet all of them. One of the, if not the largest, women's heart health program in the country in terms of the breadth and depth that we have. In addition, Stanford has cutting-edge cardiovascular research, as you all know, and they're certainly revealed worldwide, and we need that. And what we really need is we need each investigator to think about their research from a sex difference perspective. So we're not asking our scientists to do different research. We say, do what you're doing, because you have very interesting research and you're doing great, innovative stuff. But take that extra step and look at it from a sex difference perspective. And ultimately, in giving our scientists the infrastructure that they need to do that kind of research, in addition to their regular research, we can build Stanford into a leader in sex differences in cardiovascular disease. And in doing so, I ultimately believe that this will spread to other areas of medicine at Stanford and beyond, certainly ultimately across the country and across the world, because our big vision is to really change the way that medicine is practiced in this country. And I think it's something we can't do by ourselves, and that's why we're all here together, is that we need, community leaders as well to understand the importance of this and to come out and say, this is something that really matters. This affects my health every day. I expect better health care in this country for myself and for my family. So part of it is getting the word out and talking about this. Why is this going on? The other thing is, really supporting anybody that's working in sex differences so that we can, take care of this and giving people, this sort of infrastructure that they need ultimately to improve the education and the clinical care and the research that we're doing. So I think with that, I didn't show this video. I guess I could. I got talking, and so this will give me a little breather. But so this is something many of you might have seen. But the American Heart Association, of course, has been wonderful about heart disease in women. And this is a commercial that they came up with, or a little PSA, and it kind of reflects some of the things I was talking about with women and heart attacks.
A few years ago, Dr. Kibbe was using marijuana to study a problem. Okay, move objection deadline to refer my after survey. What are you doing down there? Did you finish your breakfast? Hey, you gotta eat something. Here. Okay, 5 minutes to carpool.
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly. Okay.
You sure you're okay?
I'm fine, sweetie.
I'm so late. What are you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite. See you guys later.
Where are your shoes? Put your shoes back on, please. Go help your sister. We're going in 3 minutes. Oh, God, what am I doing? I forgot to cut off the crust. Wow. Shoes on, potty if you need it. Get your sister. Here. Go in! Take your dust. Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack?
Totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not going to wait. I'm sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long?
2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart, and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
So that's a nice one. Also very true.